Yeah.
Okay, you just tell me when you'd like me to move forward
All
and I'll do
right. Yeah, go ahead and let's go to the first slide. We're going to go quickly now, and I'll try to make sure that we still have time for questions. So it's no big surprise that the entire United States is really experiencing increases in syphilis. Certain states and counties are having a higher burden and a higher number of new cases than others, of course. And here in Arizona, as well as in New Mexico and California, we have some of the highest burdens states and counties in the country. And CDC has recommended, on top of IHS recommendations, that any jurisdiction that has a rate of cases where you have 4.6 per 100,000 population of women do universal screening. And that is a congenital syphilis prevention measure as well as an adult syphilis prevention and control measure. So those states in dark green have met or exceeded that threshold. Next slide. And in addition to that, we have seen this evolution over the last decade of high rates emerging across the US, including Alaska and Hawaii, and affecting primarily the South, Southeast, and Southwest. Next slide. And we see that, particularly among American Indian Alaska Natives, the gender distribution is nearly equal or much more balanced than what we see for other race ethnicities, where the predominance or the higher rate of cases is among people who are of male gender. So who are born as males. And this you can see as the top line on this butterfly graph. Next slide. And then overall, of course, American Indian Alaska Native patients, as you are aware, do have the highest rates of adult primary and secondary syphilis. And this is also for 2003. And we expect the 2024 data to come out very soon. Next slide. And then when you see the cases, the primary and secondary syphilis by race ethnicity, you can see that even though the rates are very, very high among American Indian Alaska Natives, this doesn't reflect a high number of cases. So the highest rates do not reflect the highest number of cases, whereby we have only about 1,400 total cases in American Indian Alaska Natives, and that is in comparison to nearly 18,000 in white persons. Next slide. Here are the states that are most heavily affected, those in dark blue, including Arizona and New Mexico, which are primarily due to tribal increases, as well as Montana, South Dakota, Oklahoma, where we have high rates and emerging rates of syphilis. Next slide. And this is just, if you watch this slide, it will show you the evolution of the increases in rates. And I think this is something that we are seeing slow down, but has not really turned the corner. Next slide. Here are the rates. I do have South Dakota highlighted because this is the state with the highest rates of adult and congenital syphilis currently in the US. And we do see high rates in Arizona and New Mexico, but they are not quite reaching the rates that we are seeing in South Dakota. And in California, you can see that there are some border counties with high rates of syphilis, and this may be reflected in some of the numbers that you're starting to see. Next slide. Here are the rates that are listed in ranking order from highest to lowest. And I've mentioned this a few times, but also note that in the top 10, we have about 5 or 6 states which have high numbers of American Indian Alaska Native cases. And that's reflecting in some of the rates that are higher in these states overall. Next slide. It's a bacteria that causes syphilis. It's called Treponema pallidum. It's a spirochete. That means it's a corkscrew shape, sort of like we see for Helicobacter pylori, and the other bacteria that cause Lyme disease, for example, and leptospirosis. It is curable with penicillin, the old-fashioned, the oldest antibiotic. We look at syphilis in stages, and we use stages to gauge infectiousness, transmission risk, and the type and duration of treatment that we can use. So we'll go over those now. Next slide. All right, so overall, just important to remember that syphilis is a sexually transmitted infection, but it is also transmitted vertically from mother to child during pregnancy. It can be transmitted horizontally due with contact of the infectious lesions on someone's hands or by otherwise coming into contact with the organism, potentially through blood transfusion. Mothers can also transmit the organism to their young children by chewing the food and putting it in their mouth because syphilis is very much goes to the oral cavity when patients are exposed in that area. It occurs in stages, and the incubation stage is about 3 months, sometimes and frequently shorter. Primary, secondary, and early latent stages are those where we consider their infection risk to be the highest. Late latent stages are when patients don't have any symptoms or don't relapse to symptoms. And then we have very late stages, which we frequently refer to as tertiary. All of these stages can be affected by syphilis that goes to the brain and the cerebrospinal fluid, and all of them can be affected or can have as manifestations eye and ear symptoms and sequelae. And then it's important to remember that all of these stages can result in transmission to an unborn infant or fetus during pregnancy. Next slide. The primary stage is where we have the chancre, which is the site at which the organism has first cored through the mucous membrane or the intact skin and causes a lesion at that site. And so it frequently tells us what type and in what anatomic areas the patient has been exposed to, because that's where the lesions occur when we can find them. They are painless. They are teeming with the spirochetes, and so these patients are highly infectious. Usually it's one chancre, but it can be multiple, so there's no specific rule. And this particular stage is curable with 1 dose of penicillin. Next slide. When it advances to the secondary stage, generally the patients have resolved their primary infection or their primary chancre, but sometimes patients who have immunodeficiency infections like HIV can have primary and secondary symptoms at the same time. Secondary stage is more diffuse. Patients often don't, and even providers don't often connect the reported history of having a lesion with these types of symptoms because they occur far apart. And the symptoms are so unusual, and they frequently mimic things we see for other autoimmune diseases, allergies, rashes that occur seasonally, and patients also don't connect this with a sexually transmitted infection. But palmar plantar rash is what we really look for frequently upon physical exam, or lesions on the tongue and buccal mucosa. And then, of course, in genital exam, you can find condyloma lata in female patients and male patients, which we frequently are misdiagnosed as genital warts. And then, of course, hair loss in the eyebrows, pubic area, the scalp. Patients can lose the hair in their beards and in their eyelashes as well. Next slide. And then after these symptoms resolve without treatment of both primary and secondary stage, patients progress into the latent stages, which occur without symptoms. Early latent stage can occur with relapse of symptoms, but frequently patients don't even have or have not noted any symptoms. Early latent is within the last year, and patients who have positive labs for syphilis but do not have current lesions or current clinical findings associated with syphilis should be asked these general questions. And questions are related primarily to report of symptoms in the last 12 months or sexual contact with a known contact who is reported having syphilis, a sexual debut within the last 12 months, or the providers can calculate an interval from a prior negative test to a current positive test. And if that is within 12 months, then that can be ruled in as an early latent syphilis case and stage, which is important because these patients also only need 1 dose of penicillin. Next slide. And then we have this sort of bucket of cases, unfortunately, to use that term, where we can't really figure out what the timing of infection is or the duration of infection. And those are patients that we just categorize as having syphilis for greater than 12 months or an unknown duration. And the questions to ask these patients are similar to what we have in the early latent stage. It's just where you have seen a prior negative test greater than 12 months ago, report of symptoms greater than 12 months ago, sexual contact with a known case greater than 12 months ago, etc. And then neurologic or ocular signs or symptoms without evidence of acquiring infection in the prior 12 months can be thrown in there as well. Next slide. So the best thing to think about is, because of the complicated nature and the outbreak type situation that we're in for many tribal areas, both CDC, as my very first slide, and the Indian Health Service recognize that generalized universal screening is recommended on an annual basis for all patients that are seeking services within Indian Health Service, as well as Urban Indian Health Service and tribally run health clinics and facilities. And so this testing is for those 13 and older, and generally the question about sexual risk or sexual activity can be asked, but keep in mind that some patients are not willing to talk about sexual exposure or sexual behaviors, so it doesn't always give you the best answer. And please also remember that syphilis is highly infectious through oral receptive and oral sex generally. So it's important to recognize that some patients don't consider oral sex to be sex. So the general recommendation for universal screening can be facilitated with protocol-based delivery. That means providers that are taking care of patients, such as nurses, may be able to get a protocol for their facilities that allows them to collect specimens and order syphilis testing, in addition to other STI testing. And then EHR clinical reminders in the electronic health records are also very valuable. And then expanding screening in urgent and emergency departments is very important. And then recommends the IHS as well as CDC recommends 3 time points syphilis screening. It's universal for IHS for all pregnant patients at the first prenatal visit, in the beginning of the 3rd trimester, and again at delivery. And then CDC's recommendation again is based on high rates in that particular geographic area. All of these recommendations are in a Stop Syphilis letter that was put out by the Chief Medical Officer, Dr. Christensen. And I think our most updated letter may even be in July of 2024, but this can be found on the same site, and the link is below. Next slide. Best practices again is offering, these are IHS best practices with this dark green border at the top, is to also offer express testing. That's a test without a physical exam, also without a clinical appointment, where patients can walk in potentially just to the laboratory window and ask for STI screening tests, and they can be screened based on a standing protocol and at their own timing, volition, and at their own request. And this is considered a best practice, as it saves time and it also reduces provider time and patient waiting time as well. Next slide. And then we also recognize and strongly recognize the overlapping epidemics. And this is both a recognition at the national level, also at the Indian Health Service level, and is also recognized by CDC in their development of integrated plans for hepatitis, STIs, as well as HIV. And what it ultimately means as far as service delivery is that we should be offering what's called a syndemic bundle. And that is screening, of course, for syphilis, as well as other sexually transmitted infections, and also recognizing that at least chlamydia and gonorrhea can occur and can be localized to the rectal area, vaginal area, and oropharynx. And thus we need to test at those sites, because if you only collect a urine, you may actually miss chlamydia and gonorrhea in that regard. We have seen very high rates of hepatitis C in some of the areas where we are doing syndemic bundles in our response to syphilis increases. And it's also very important to remember that pregnancy is sexually transmitted. It is a sexually transmitted condition, and not a single person who has a pregnancy should go without testing for other sexually transmitted conditions and specifically infections, including those listed here on this slide. Next slide. Serologic diagnosis of syphilis. It may be important for you to recognize that your facility may have something that is alike or different to that of the next closest IHS or Urban Indian Health or tribally run health clinic, because there are different ways to do it. But the bottom line is you need to screen and confirm, screen, confirm, screen, confirm. So it's a two-test sequence. And the traditional algorithm starts with a non-treponemal test, and the reverse sequence starts with a treponemal test. You're welcome to review this algorithm, but we don't need to belabor the details of it. Rather, remember that it's a two-test sequence, and it's important to check in with your lab to see what's being run. Next slide. Patients who have a treponemal test result interpretation, it's important to note that a treponemal test result can indicate a positive or a new infection, can also indicate an old untreated infection, and it can also indicate an old treated infection. So as a limitation to a treponemal test result interpretation, remember that you need to get another non-treponemal test to diagnose active infection. Okay. So, and then remember also that it is a great test to rule out syphilis, meaning that a negative test result can indicate no infection. Sometimes testing for someone who has just been exposed and infected with syphilis, any test can be negative if they're too early in the incubation period. So this test result is something to consider and understand when you're looking at your algorithm and also reviewing your test results. Next slide. All right. The Indian Health Service has put out some new guidance, very helpful, very easy to read guidance on understanding treponemal and non-treponemal test results. And non-treponemal tests we use to indicate a new infection on top of an old infection that was treated, where someone becomes reinfected, and also to understand the treatment success with regards to seeing a decline in non-treponemal titers. Today, we don't have enough time to go into each of these individual scenarios, but please keep this as a reference. And also, Brig and I can reach out to you and send you printed materials where these are highlighted and explained further, but we'll of course make these slides available to you. Next slide. And then we also want to make sure you are aware that in addition to those non-treponemal and treponemal tests that are serum-based through blood draw, we have two FDA-approved rapid syphilis tests, which can be done in an outreach setting, which are oftentimes used in an outreach setting, and which we do have some IHS level experience with use. The first is Syphilis Health Check. It is a single syphilis only test, 10 minutes for results, and it will be positive in patients who have had syphilis in the past and who have been successfully treated in the past. So both of these tests, both of the rapid tests, should be prefaced with a question to patients whether or not they have had syphilis in the past. And in that regard, those patients can be tested with these tests, but they should also have a blood draw as well for confirmation. Next slide. The second syphilis test is a rapid dual test, which also tests for HIV within the same blood stick and within the same cartridge and using the same reader that clicks in to give an interpretation. And the results are available in 15 minutes. And it is a little handheld reader that allows you to get a specific test result for patients without having to rely on your own vision, which of course these lines are pink, so people who have color blindness can have some different interpretations, and especially in low light areas or where sometimes outreaches are provided. Next slide. Okay, also to highlight, we have an Indigi I Want the Kit, which allows patients to order their own test kits for not just syphilis, but also HIV, chlamydia, gonorrhea, hepatitis B and C, and trichomoniasis. So we encourage you to share the information in the indigenous iwanthekit.org, and that information is on the bottom. In addition to that, now there are over-the-counter test results that are FDA approved, where patients can get the syphilis test and conduct the test and interpret the results on their own at home. So that has been recently authorized by FDA. Next slide. And again, we also have options for syphilis tests where we can facilitate getting patients. I want the kit, the testing materials for that, and patients can text native test to that number 55251. Next slide. All right, so point of care, here are some considerations for implementing that. It gives you specific step-by-step instructions and eligibility and best case scenarios for where to use it. This was put out actually at the national level by the Federal Task Force for Syphilis and Congenital Syphilis Response, and that's available with the link at the bottom. Next slide. All right, so we're starting to get into treatment now, and here's also a very helpful algorithm for screening, diagnosis, and treatment. In the beginning, when we first have potentially a rapid test that is positive in a patient who's never had infection, or even a serum test that's positive in a patient who you are aware of has never had an infection that they remember, we do recommend giving that first penicillin injection after you assess for penicillin allergy. Patients we frequently see sometimes do have a history of syphilis in the past, so we like to do a further review with the health department surveillance records, and we also like to interview the patients to understand whether or not they need a second and third dose. And those second and third doses are determined by their prior history of syphilis symptoms, prior history of having sex with a person who has a diagnosis of syphilis, prior sexual debut within 1 year. And you remember that within 1 year period helps us decide whether or not to give them one dose, which is needed just for those primary, secondary stages and early latent stages, or whether we have to default to 3 painful injections of penicillin when we cannot stage the patient with any other stage other than unknown duration or greater than 1 year's duration. Next slide. And then we want to make sure, and I've already said this, so we won't take too much time, taking a sexual history is really important, and also connecting with the health department to do a record search and a record check so they can help advise on treatment duration and prior diagnoses. And then what's of critical importance for community-based transmission and also stopping spread is to trace the sexual contacts so that they can be brought in for presumptive treatment and testing, staging, and further treatment as necessary. And these are all available within the printed resource materials that I mentioned. And we're happy to try and get an order out to you so you can share them with your providers. Next slide. So penicillin, we'll talk briefly about penicillin. It is the treatment, it is the cure of syphilis. We don't have any documented resistance, and we do recommend that is the first line treatment. Benzathine penicillin is a lipid-based formulation. It is an injectable into a large muscle group, preferably in the buttocks and the hip area. And it is something that we have experienced shortages recently, and even have some reported shortages even today. And it's important to recognize that having an adequate stock in your clinical facilities is very important. Assessing for penicillin allergy and understanding that even pregnant patients with penicillin allergy need to receive penicillin after they undergo desensitization. Next slide. So the stage, I'm going to remind you quickly that primary, secondary, and early latent stages of penicillin only require a single dose of 2.4 million units. Frequently, it is packaged as 1.2 million unit syringes that are pre-filled, and we have one company that provides those, Pfizer. In shortage situations, which we've had recently, we are importing other drugs from France and Portugal, and those come as powder formulations. When the patient has a late or unknown duration stage, they need 3 injections of 2.4 million units, and those are spaced by 1 week intervals. Patients who have neurosyphilis, who have ocular syphilis or eye syphilis, and those who have syphilis affecting their ears need IV crystalline penicillin administered in a hospital setting over the course of 10 to 14 days. Next slide. All right, so here's the treatment based on stage for primary, secondary, early latent. We have 1 dose, 3 doses for exposure or infection greater than 12 months ago, an IV penicillin for ocular, otic, or neurosyphilis. Next slide. All right, this is how you give it. I'll let you take a look at that a little bit later. There is a mini video where you can watch them injecting. And those are the sites where you want to give it. The upper outer quadrant, that is, those red X's are not the no signs. They're actually the target areas. And this is the best way to position a patient because some patients do have a lot of pain and can faint. So we like to lay them down. Next slide. All right, field treatment. We like to see, we have a lot of IHS facilities and some tribal facilities that are taking penicillin into the field. We like to do that to make sure that we get patients treated. This is an IHS best practice where we take the treatment out to the patients and administer it in their home, especially those that are pregnant, having transportation difficulties, child care concerns, or other privacy and mental health issues. Next slide. And then presumptive treatment is a term we like to use for patients and giving penicillin prior to having positive test results. We give penicillin without a positive test result for patients who have symptoms consistent with syphilis and also for sexual contacts to syphilis cases. We draw the blood and we give the penicillin before the results are available. And also for patients who test positive on a finger stick prior to getting that confirmatory test result. So this is presumptive treatment with penicillin. Next slide. All right, penicillin allergy. First of all, remember, anaphylaxis is very rare and allergies to penicillin wane over time. Thus, a penicillin allergy you're diagnosed with as a child is unlikely to be present as an adult. So we do have recommendations for penicillin challenge through the Indian Health Service, and I'll talk about that. But remember that for those who have true penicillin allergy, they need to get an alternative antibiotic. And if they are pregnant, they must get penicillin because we don't have an antibiotic that appropriately crosses the placenta, or we don't have an antibiotic that is safe in pregnancy. So we're working on that globally, but for the moment, penicillin allergic women who are pregnant still need to get penicillin and they have to be desensitized. Next slide.
Mel, you're at 40 past the hour, FYI.
Oh, perfect. Okay, we'll go ahead and breeze through some of these last ones. Here are some alternative recommendations. Remember that those in light blue do not cross the placenta, and this is not optimal for treatment of patients who are pregnant. Next slide. And these are the reference materials. So again, we can reach out at a later time to get these to you. Next slide. These reference materials include oral challenge with amoxicillin for patients who are allergic and an oral challenge with amoxicillin to potentially remove the penicillin allergy and prescribe penicillin for syphilis treatment. Next slide. All right, here's how to use the PenFast tool. And this is something you can review at a later time, but it basically requires you to take a history and determine a score. Next slide. Those who have a score of 1 to 2 are very low risk. You can give an oral penicillin challenge. Next slide. In the oral penicillin challenge, if its patient doesn't have any allergic reaction, you can prescribe penicillin. Next slide. All right, let's talk. This is a slide. We're going to talk briefly about congenital syphilis. And to remind you that this is the slide of women who are of childbearing age who have syphilis across the US, with many of our tribal counties highly affected. Next slide. Also, in association with congenital syphilis are women who have no prenatal care or very late prenatal care. This is one risk factor. Next slide. The second risk factor is a high rate of substance use. Any substance, but specifically use of opioids and other non-prescription substances such as methamphetamines. Next slide. Here are the rankings by state with South Dakota at the top. Next slide. These are some of the manifestations. The clinical manifestations are primarily related to mucocutaneous disorders. Also, elevated blood inflammatory markers, such as the RPR and the syphilis test that we use. And in addition to that, it goes to the bones of infants and also the skin. Next slide. Additional manifestations are primarily related to blood counts, causes a fatal anemia called hydrops fatalis. It can occur as a pneumonia. Skin manifestations I've mentioned, as well as a neurosyphilis type infection of the cerebral spinal fluid, which can be very severe. Next slide. All right, we're going to end with just a few slides on adult and infant case management. Really want to make sure that we're prioritizing data sharing across our public health agencies. I'm very happy to hear that you're working well with your county health departments, and support for contact tracing, which is the critical element to stop community level transmission. Next slide. Case investigation and contact tracing is the best way to diagnose and identify undiagnosed infection in communities and stop transmission. So I'll say that 2 times and we'll leave it at that, but it is really important. Next slide. And then post-exposure prophylaxis with doxycycline is a new and emerging intervention that we can use for prevention. I'll leave this here, but please remember it is not currently recommended at the moment for women and heterosexual men, but it is recommended for patients who are men who have sex with men. Next slide. And we want to work at all costs to remove barriers. I've put a few published barriers here for you to consider and review at a later time. Next slide. Patient incentives are being used to improve the rates of patients who get those second and third doses, to improve the number of people who come forward to be tested, and also to improve the number of people who are willing to give their partners to help locate their partners. Very highly effective for other things as well. Next slide. All right, IHS supports the incentives, and we can give you the contact information of someone who can provide more information on how to get those cards. Next slide. All right, we want to educate and engage the community, and I will stop here on this slide. There are a lot of media messages that have been developed by the Northwest Portland Area Indian Health Board, and we do promote those, as well as some of the shareable materials that we have here for our Intertribal Council of Arizona. Happy to share whatever works and whatever might be helpful for your area. So I'll stop, and I look forward to any questions that you might have.
Thanks so much. There's a lot of resources. I'm going to go ahead and put my email in the chat window. If there's anything that you think of that you want more information on, any of the resources that Dr. Taylor mentioned, we can get those to you and get your question answered. But for now, I encourage you to ask Dr. Taylor any questions that, from screening to policy to standing orders to staging to getting more training for your medical team, whatever you want, please take advantage of her presence, and I'll open it up to questions.